Good morning, good afternoon, good evening, wherever you are. My name is Peter Molyneux, and I'm the England liaison for the Global Leadership Exchange in Mental Health. And today we're hosting one of what we're hoping are going to be a series of conversations to mark LGBTQ plus History Month. And I'm absolutely delighted to have with us today Professor Helen Kellaspy, Professor of Rehabilitation Psychiatry at University College London. Helen, you're very welcome.
Thanks, Peter. It's lovely to be here.
I suppose it's in the title, isn't it? LGBT History Month invites us to sort of think back and to think about where we've been. And I'd be really interested in your thoughts on, where do you think we've been over the last few decades, and where's there been progress, and where perhaps has there been less progress for patient service users in mental health?
Well, yeah, in more recent decades, I would say that there has been a very kind of positive focus on understanding more about what are the mental health issues affecting people from sexual minorities. And been a number of studies, some of which, I was involved with over a decade or more ago, and more recently, that have all continued to show that there is a higher prevalence of mental health problems amongst that group. And there's been lots thought about, lots written about, thinking around why that might be. So I think in a way research has helped to sort of progress the conversation. So we know that people from sexual minorities have a kind of 2 to 3 times higher risk of developing certain mental health problems, and there are differences in different problems in different subgroups of the LGBT plus community. In order to sort of try and make sense of that, we then have to think about how people operate and how they're received and how they live, and how they interact with the community. And of course that leads to lots of discussion about alienation and marginalisation, stigma, discrimination, minority stress theory, all those areas that have had a kind of very rich literature and lots of rich discussion. And I suppose all of that means that we've been able to talk more openly about these things than obviously people could, 30, 50 years ago. So I think that evidence, being able to go out and start to think about how one might research has helped open the conversation up. And of course, I'm saying that with the bias of being someone who likes research. And of course, there are many other groups and movements that, of course, had to move things forward from a different sort of more activist position as well. In terms of where we're at now and how it might be different, I mean, from a sort of personal perspective, I think when I was at medical school, there's no way I would have spoken about my personal life. I would never have, I'm barely conscious of being out. That just is very different now. Me being able to sort of have this conversation with you, knowing that it will be in the public domain, doesn't cause me any stress, but it also is, and that's partly because society is more accepting. So, the whole kind of landscape has shifted to be more accommodating, more accepting in some ways. But of course, the process by which one gets there to being kind of more understanding of oneself and more understanding of other people who come from different identities, different groups, is a slow process. And of course, it's accelerated if you have personal experience or people in your network, family, that kind of make you have to think about it and work on that. And I think in terms of how people accessing mental health services might experience things, it's clear that actually we haven't really shifted forward very far at all. We're still having reports of there being quite a lot of difficulties for people being able to feel safe when they come out, when they're talking to mental health staff, or knowing how to do that, not being made to feel that would be an easy thing for them to do. And I think that's a real shame because, again, kind of referring back to research, lots of research about what we need to do to improve the confidence and the competence of mental health staff in working with people from sexual minorities. Lots of research from many decades. I think the first thing to say about that is that most people who go to see a mental health professional are not presenting with, their sexual orientation as the primary problem. It might be, but, they're just as likely to be presenting with any other reason, that's causing them mental distress. So the sort of assumption that everything is due to their sexual minority identity is, of course, one of the biggest problems. So it sort of looms large in the mind of the professional, but actually may not be looming large at all for the person who's coming to seek help.
So is it, I've lost count of the numbers of times I've seen data that says that people who are LGBTQ plus are overrepresented within mental health services. Is it that we focus a bit too much on what the causes of that might be, rather than necessarily thinking whether we need to respond differently? What do you think the evidence is pointing us to?
Well, I think first of all, I'm not sure that they are overrepresented, because that's right. I think it's often a kind of phrase that is used when what's really meant is that there is a higher prevalence in that group, but that doesn't mean they're getting to mental health services.
Right.
So, population surveys have shown, say, these sort of very consistent findings of these rates of 2 to 3 times higher. But in terms of who actually gets to services, or whether we even know what their sexual minority status may or may not be, I think we haven't got there at all. It's been decades that we've been recommending that information data on people's sociodemographics should include their sexual orientation. And that, of course, is still very incomplete. Staff may just feel uncomfortable about asking someone at the first time that they meet them, and they may only meet them once. And of course, that meeting is terribly important. And that discomfort might be on the part of the staff, or it might be the other way around, that they feel like this isn't appropriate for whatever reason from what they're picking up from the person who's come to see them. So I think those sorts of simple interventions where we just ask in the way that we ask all sorts of other personal information for kind of checklists when people first access services is something that to me just seems like a very simple intervention that could actually help not only open up the conversation for people, but also make them feel like this is a safe service because they're even asking about it on day one. But also, of course, it would give us more information to be able to say whether or not they're truly overrepresented.
So what are the things that you think would shift the dial? You've talked about it in some ways it is as simple as asking the right questions. Yeah. What else might shift the dial from your perspective?
Well, I think there's a lot about asking the right questions. It's not easy to train staff in cultural competence around sexual minorities through a 5-minute online CPD mandatory training module. It's amongst all the other mandatory training modules that staff complete. I think that we do need some of that, of course, but we also need to be able to have some more specific face-to-face interactive, more thoughtful and sort of personalised opportunities for staff to, learn more about the lives of different people. Sometimes, you can come across staff who've just come from such a different background that it actually becomes very nice to hear about and learn about each other's lives. And I think we could promote more of that kind of sharing. Of course, there's the other side, the other way of doing things is obviously the kind of the nice sort of trying to share and improve people's awareness through those sorts of activities and events. The other side is making it very, very clear that should you overhear or witness anything that you feel or experience as oppressive or wrong-worded or indeed overtly homophobic, that of course that's entirely unacceptable, and that the organisation is set up to be able to respond to that very clearly. In fact, one of my favourite interview questions when we're interviewing new staff is about homophobia. It asks, what would you do if you overheard a member of staff saying something that you thought was homophobic? I'm not going to tell tell the answer on this screen, because obviously I want to carry on using that interview question. But, interestingly, a lot of the kind of standard questions at interviews around diversity do not focus on sexual minorities, they focus on other protected characteristics. So things like that just raise consciousness and awareness for the other people in the interview panel, let alone the people coming for interview, that this is an organisation that is interested in this and thinking about it. So I think there are lots of ways in which we can try and sort of raise awareness, raise consciousness, raise competence for staff, as well as sort of very targeted training.
Do you think we're doing enough within medical education and nursing education? Is there more we could do there?
Yeah, there will always be more we can do there, and I think there's a lot more we can do there in training of mental health professionals in reality. And there are, there are all sorts of different ways of, for example, examining medical students, but also training psychiatrists. And, increasingly we are seeing hypothetical scenarios that include issues around sexual minorities. So I think that message is slowly filtering, but certainly it could be expanded.
So how important do you think it is that we come together as groups of people who are LGBTQ+? I'm aware there's a special interest group within the Royal College in the UK. Obviously, the Global Leadership Exchange also has collaboratives, and it has a 2S LGBTQ+ collaborative. I mean, what do you see as the importance of networks in this space?
Well, I mean, networks are important because it is important to be able to get together with people who, you have something in common, particularly when you're trying to sort of do work together that improves the situation for your colleagues and for patients who access services. So I think there's a peer support function, first of all, that comes from that. And like any group, groups have their own challenges and dynamics, and that's helpful because it reflects the kinds of challenges and dynamics that are likely to be out in the wider community. And of course, those groups are really potentially very, very powerful because just by existing, they give a strong message. This organisation recognises the importance of people from sexual minorities. It has its own group, focused on that. So, being there, being on the website as part of the organisation is, I think, it's another kind of marker of an organisation that's healthy. But the actual work of those groups, of course, can be really powerful. Obviously, campaigning, responding to consultations, funding and following research, giving advice, developing training models, all those sorts of things that, do need some expertise and some focused time can all come from those sorts of groups, as well as, a social network potentially.
And I suppose listening to you talk, Helen, that it seems like there's something there for the way in which research and evidence can come together with activism and campaigning, and then think about, well, actually, how do we then translate that into the kind of insider leadership that we need within service providing organizations?
Yeah, and the disciplines of leadership itself, management and leadership, using data from good research, thinking about implementation of interventions that are going to change practice and improve quality of care. All of those things are needed to affect very positive change in this area. And so I think it's never down to one of these sorts of areas or disciplines to be able to do it. You need all of these things, and they work in slightly different ways on slightly different people who are leaders in the system. But they obviously do need to work together. So I guess that's another good reason for having collaborations and networks that can bring people with these different skills and strengths. My sense of how things how to affect change really is to bring people with these different skill sets together. So, we do need researchers and academics who are exploring specific questions, trying to identify and address important questions that can move things on. We need the people who, can then effect change through policy, and sometimes that's activism, sometimes it's obviously people who are specifically working in policy who have an interest. We need leadership and management to be able to implement the things that come from that. And all of those things need to work together. They're all sort of different parts of a kind of a whole, and without all of them, you're never really going to change things. That may come back to what you said right at the beginning, actually, as to how things changed. It's a little disappointing, really, to feel that we still know that there's this higher risk of mental health problems amongst people from sexual minorities, but have we really improved mental health services to address that and to make it more possible for people to present to services? And I don't think that we have. I think we're getting there, but we're getting there rather slowly, rather too slowly, given what we know could work. So, I think more can be done, and we need to accelerate that. It's interesting how things, this topic doesn't often reach the top of the chief executive's pile in an organisation. And that's where activism comes in, and service user voices can be very powerful in trying to move it up the priority list.
Well, Helen, I know that you are going to continue to try bringing it up the priority list, both within service providing organisations and within academic institutions and within colleges as well.